we're talking about taping for the pregnant abdomen, there are a couple things that you want to make sure of when you're taping. And one of them is that when you're looking at the tape, the best part that we want to remember about this is that we're not taping to stabilize. We're taping because we want to provide support around the pregnant abdomen and allow for flexibility, because we still want the baby to move, right? And so the objective here is I'm going to lay this tape down without any tension. I don't want to move any of the hexagons. I want to make sure that it's nice and neutral. So the idea being that my first piece of tape is going to start at the pubic symphysis on the patient. And I'm going to start off with the most lateral aspect on, it doesn't matter which side, sometimes it depends upon which side the baby's laying, so it may move as you're doing this, and that's an okay thing. But most of the time I will start on the opposite side, furthest away from me as the practitioner, and then I will come over and do the side closest to me, okay? From there, what I'm going to do is then tape from the pubic symphysis again, over the top of the abdomen, and right around the umbilicus on the patient. Again, the other component that we want to make sure of when we're doing this is that we tape up closely to where the costo region is, because we want to get to the ribs. Thinking about where baby's head is, thinking about where baby's feet lie, that will also help us as we get ready to lay the tape. Okay, so we're going to go ahead and get started with the first piece of tape. Again, usually because it's close down to the pubic symphysis, I tend to have the patient go ahead and place the tape, because again, we're getting into a sensitive region. And so I'm going to go ahead and start with the first piece. Again, here with pubic symphysis, I'm going to go ahead and make sure that I'm on that marker, because that's going to be the first place that I start. As I get ready to lay down my anchor, okay, here's pubic symphysis on our model. And again, I don't want to add any stretch. That's the first piece that it becomes really significant to me as I get ready to anchor and I get ready to wrap the piece of tape around. Now, as I get ready to anchor, you notice what I did, because we're taping a longer piece, I do want to make sure that my piece comes up to, and in this area, we're talking about the area of the costals or the ribs on this patient is going to be in this vicinity. Remember also though, when we're talking about pregnant patients, we tend to see larger breast tissue. Okay, so when you're working in this region, again, typically I will have the female patient lift up the breast tissue so that we can make sure that we're actually taping in the right location. Now, I'm going to lay this down so that you do get a good perspective as I get ready to pull the tape, and I'm going to lay it down. Now, because we're on a model, things don't always work as well when it's not real skin. So we're going to work on this and make sure that we bring it nice and around. Okay, I'm going to go ahead and activate the tape. And again, if you noticed, it just went down to tape tension. That is super important when we're doing this. Now I'm going to go ahead and tape closest to me, and I'm going to overlap on the anchor, because again, I want to support that pubic symphysis. I want to bring it all the way around, going up to the rib location. Now, this one in particular is cut shorter than the one on the contralateral side to me. I did that on purpose, because let's say baby is rotated a little bit, okay? And let's say we're actually feeling some of the contralateral aspect of the ribs more prominent than on the opposite side. So again, really finding where the rib junction is going to be important as I get ready to lay this down. Because after all, we just want mom to be comfortable. And that's the bigger piece, is as we're getting ready to do this, we want her to be comfortable and not restricted, because that's not the goal of this. It's really more of the goal of support. So as we get ready to tape, thank you. As I get ready to tape, again, I'm going to go ahead and lay this down, adding no tape tension. I'm going to go ahead and wrap this around, and I just told the others that what we're worrying about here and concerned with is how baby is rotated in the abdomen, because that's going to play the biggest part. So as I get ready to lift the tape and lay this down further, okay, I'm going to just bring it nice and around. No stretch on the tape, just laying it down to tape tension. Okay, go ahead and activate the tape for mom. And now she has a beautiful sling. Some moms will say this is enough. Some will say you can stop with just this. And some say they feel a little bit more comfortable if we add 2 more strips right along the midline. So I'm going to go ahead and add the second layer of strips. Now, here's the piece that also, if we have a patient that's pregnant with twins, sometimes what we can go ahead and do is continuously wrap this tape up and underneath the breast tissue and we can go all the way up and around to the opposite side. So we end up creating almost like a figure 8. And that will lift up that pregnant abdomen and again take pressure off the pubic symphysis. That's what we're looking for when we do this. So I'm going to go ahead and tape the midline, okay, because we're pretending that we don't have twins or we don't have multiples at this moment in time, and that we're really just helping take pressure off that pubic symphysis. So let's go ahead and lay down for the midline. Okay, so here we are. I'm going to place my anchor, and again, it's a little goofy with the model. And we're going to go ahead and lift the tape. And I didn't fold my tape. I didn't fold my tape on the edge. I got distracted because I wanted to tell you what I was doing and not paying attention to myself. So here we go. We'll just bring it all the way up. Okay, now pretending umbilicus is right here. Okay, so if umbilicus is right here, we do want to make sure that, again, we're taping right across there in the midline. Again, assuming that ribs are right in this region. Okay, keeping contact and making sure we're in the right locations. Here we go with the next and final piece. Okay, and I'm going to go ahead again. I'm going to lay down my anchor. And as I get ready to lay down my anchor, one of the other big things I'm still watching for is making sure baby's not shifting around while I'm doing this, right? Because again, I don't want to be restrictive. So we can go ahead and palpate where baby is. Maybe sometimes we'll see if baby has shifted and changed. Okay, so I'm going to go ahead and lay down my anchor again. And as I get ready to do this, one of the big things that I want to be watching for too is making sure that mom doesn't feel too much tension on that pubic symphysis. Okay, making sure, again, it just feels nice and supported. Umbilicus is right there, and here we go as I get ready to lay this down. Okay, so again, so she's got this nice supportive abdomen. Okay, again, making sure, checking all my hexagons. I do that as like my last final step, making sure I didn't overstretch, making sure it is purely tape tension. And so when we're finished and mom stands up, she should say, I feel really comfortable. Okay, and again, we want to make sure that we're giving instructions how to take this off, because especially on that pregnant abdomen, right, especially in the location where we're stabilizing, maybe a little bit more uncomfortable for mom. Okay. So the next thing I will do is if they're having some low back pain, or I'm not sure how this is going to work, lay her on her side. Okay, so as we get ready to tape, a lot of times too, if she's having, say, SI joint pain, I'll do one of two things. I may tape the anterior aspect, and I may tape the posterior aspect. I may just tape the posterior aspect as well. Okay, it just depends. Now, one of the big things that I will do is if she's having SI joint pain, just to give her some stability, I may go ahead and just tape both of the SI joints. Okay, and just tape across to give that lumbar support. I didn't do this, but sometimes also what I will do is I will tape across the SI and then go ahead and tape up against the lumbar spine. Okay, really just determine it. But my favorites are to tape that anterior aspect, tape across, and then create an asterisk over the side that has the greatest amount of pain. Those are my absolute favorites for this. So again, I'm taping on an angle, okay, which I typically don't do with these pregnant women, but we're going to make this work, okay, for us. And one of the other big things that I want you to notice, we're going to say that her SI joint is somewhere in this location on her abdomen. On her abdomen, yes, on her posterior aspect. Okay. Again, when I'm talking about pregnancy, I don't add tape tension, even on the posterior aspect. I want to just make sure that I lay it down, anchor it, and just lay it. I don't want to add stretch, because a lot of times they're super hypersensitive, and I just want the tape to be there as support. Okay, so that's going to be the next adventure with this. Now, one of the other big things that I find super important with this is that, again, because sometimes these patients have never been taped before, and if their sacrum is super sensitive, that you also give them that trial location of, okay, maybe we don't tape the abdomen first. Maybe we start just with the lumbar spine or the low back. because again, it will help ease into more tape being onto their skin. The last and final piece that I would do is if there was a certain SI joint that hurt more, I would then go ahead and lay down the tape to tape tension and tape the asteris. Okay, that would be the final piece associated with the pregnancy protocol piece. So again, looking for, depending upon which SI hurt the most, I may move it around. If she's having some piriformis pain, I may actually move it down a little bit closer to the piriformis and may go into the lower SI. And again, really dependent upon where she's feeling it at the most. So that is what I would do for a pregnancy tape protocol. The next portion we'll move into will be the postpartum piece. So the next piece that we're going to talk about is posterior pelvic tilting for some of our postpartum patients, but then also some of our patients that are reporting pelvic floor dysfunction. So one of the big things that I want to focus on is that pelvic floor dysfunction doesn't always happen to patients that are postpartum. It can happen at any age. It can happen to athletes. It can happen to the general population. But we do see it commonly postpartum. And one of the big things that we can focus on when we're talking about pelvic floor dysfunction is that we need to be working on bringing proprioception back to the pelvis. Now, you could have the patient sit on a physio ball and work on proprioception that way. My favorite is to take one of the overballs and really provide focal proprioception to the pelvis, because again, you're trying to rehabilitate the pelvis. That's what you are focusing on. Now, when we talk about pelvic floor dysfunction, it is consistently associated with transverse abdominis, diaphragm, and also multifidus. They have to work synchronously along with the pelvic floor. But one of the things that we can work on is we have to determine when we're trying to identify if it's function versus strength, how we're going to rehab the patient. So yes, they can work on Kegels. It's an appropriate form of rehabilitation, but one of the other things is using the overball to provide the proprioception and work on posterior pelvic tilting, because that will help with some of the core stabilization that we're looking for and bring proprioception back to the area. So what I'm going to have my patient do, she's laying supine, we're going to have her lift up. We want this to lay just inferior to her sacrum, okay? And then as she gets ready and she gets stable, we're going to then have her do some posterior pelvic tilting. As a practitioner, I'm not going to walk away because I don't want her to lose her balance, especially while she's on the overball. So I'm going to have you lift up for me. And I'm going right about there, I think. Does that feel even for you? Good. Okay, so the patient will go ahead and move that to make sure that it's a little bit more on the even aspect. She's going to make sure that she's balanced, right? And I'm going to make sure that she's balanced, because the last thing that I want her to do is start to roll. Now, as she's got the overball underneath, I'm going to ask her to work on posterior pelvic tilting. So remember that as we have her do that, we're going to have her roll her pelvis into the table, flatten out her lumbar spine. Okay, are you ready? So we're going to go ahead and do a posterior pelvic tilt. We want to look really closely at her working on the pelvic tilt and go ahead and relax and bring it back down. Good. And we'll have her do a series of these to go ahead and, like I said, work on the core stabilization in the abdominal region, and then also work on bringing that proprioception back. Really important when we're working on dysfunction. I'm going to do just one more. Good. And you can watch how we see that nice, beautiful convexity and concavity within the abdominal area. Okay, I'm going to go ahead and have you lift up for me. Thank you. Now, if the patient cannot lay supine, we didn't have an excellent wall here, but the patient can also stand and place this up against the wall. Preferred method of when we're looking at pelvic floor dysfunction is really trying to get them either in the supine position or working with gravity. So if we had them standing, we could then do the posterior pelvic tilting while they were standing. But the key component of this is really working on the proprioception, because a lot of times the proprioceptive piece is the piece that's missing. So with that, this is our first exercise for posterior pelvic tilting for pelvic floor dysfunction. So thank you.